Hello and welcome to the Comp Pod. I'm Andy.
And I'm Ivy. Thanks for joining us.
Welcome to the deep dive. Today, our mission is to unpack why a very small percentage of workers' comp claims, specifically occupational lung diseases, are secretly creating these massive, lifelong clinical and financial impacts.
Right, because they're incredibly complex to diagnose and even harder to treat.
And to help us wrap our heads around this, we're relying on a really fascinating article. It's titled Deep Breath: Occupational Lung Diseases in Pharmacy Management, and it was published by Healthy Systems.
Yeah, that Healthy Systems article is such an incredible lens into this because it doesn't just look at the initial injury, it looks at the entire life cycle of the disease, right down to the pharmacological balancing act required.
Okay, let's unpack this, because when I used to think of occupational lung diseases, I pictured something strictly historical. Coal miners in the 1920s developing black lung, or like factory workers in the Industrial Revolution.
Right, something from a textbook.
Yeah, exactly. But the source material points to a completely modern, unavoidable catalyst that is throwing this whole issue right back into the spotlight. We aren't just talking about underground mines anymore.
No, we are talking about the environment itself. I mean, the immediate catalyst driving the sudden influx of these claims is just the massive escalation of extreme wildfire.
Yeah.
And the environmental data here is actually really alarming. NASA reports that climate change has driven hotter weather, earlier snowmelts, and warmer nighttime temperatures. And the direct result of those ecological shifts is that our fire seasons are now a full month longer than they historically were.
A full month. I know the sheer volume of these fires is escalating, but what does the data actually tell us about the scale of the threat facing firefighters today?
Well, the National Interagency Fire Center tracked a huge spike, reporting 64,987 wildfires in 2024 alone.
It's insane.
It is. And when you look at how that translates into physical harm, the numbers are pretty stark. Like during the Palisades wildfires, there were 122 workers' comp claims filed by first responders.
Okay.
And a staggering 80% of those were for respiratory-related injuries.
Wow, 80%.
Yeah. And the financial toll that follows all that smoke is astronomical. The overall medical cost of respiratory diseases in the U.S. is sitting at $170.8 billion annually.
Wait, billion with a B.
Billion with a B. To break that down a bit more, COPD drugs alone account for $11.9 billion, and occupational asthma exceeds $1 billion every single year.
Okay, so if a typical workplace injury, like a broken arm, is a sprint for the workers' comp system to fix, you treat it, it heals, you go back to work, occupational lung disease sounds like a grueling ultramarathon. And to really understand why legislatures have to step in like that and why that financial toll is a lifelong marathon, we have to look under the hood at the biology.
Right, because the damage we were talking about isn't just a lingering cough.
Exactly. First, we have interstitial lung diseases, or ILDs. What is actually happening inside the lungs of a worker with an ILD?
ILDs are fundamentally a problem of irreversible scarring. When a worker inhales microscopic particles like mineral dusts, such as silica or asbestos or metal dust from welding, those particles bypass the body's normal filtration systems, and they lodge deep inside the tissue surrounding the air sacs in the lungs. So the body's immune system detects a foreign invader and tries to attack it, which creates inflammation.
Right, a normal immune response.
But because the body can't actually break down something like silica dust, the immune system just keeps attacking. And over time, that chronic inflammation turns into fibrosis, which is thick, rigid scar tissue.
So it's like trying to inflate a balloon that has been tightly wrapped in duct tape.
The lung literally cannot expand, and that is the biological mechanism behind historical diseases like asbestosis and silicosis.
Then you have the other side of the coin, which are obstructive lung diseases, or OLDs. If ILDs are about scar tissue restricting the lungs from expanding, what is an obstructive disease doing?
Obstructive diseases are more about blocking the pipes. So instead of scarring the outside of the air sacs, inhaled irritants like long-term exposure to diesel exhaust or chemical fumes cause the airways themselves to become chronically inflamed and narrowed.
Okay, so the path in and out gets smaller.
Exactly. They trap air inside the lungs and make it incredibly difficult to exhale. This is the mechanism behind chronic obstructive pulmonary disease, or COPD.
How on earth do doctors separate damage caused by a job from a condition a worker has had since childhood?
That's a huge challenge.
Because the article brings up asthma, and the terminology here is incredibly nuanced. So if I've had asthma since childhood, and the dust at my new factory job triggers an attack, that is not technically occupational asthma.
What's fascinating here is that the medical and legal definitions hinge entirely on causation, not just irritation. What you just
Yeah.
described is work-related or work-aggravated asthma.
Oh, because I already had the condition.
Exactly. You already had an underlying hyperreactive airway, and the workplace environment persistently made it worse or temporarily triggered an attack. True occupational asthma means the job biologically created the asthma in a person who never had it.
But how does a job create asthma from scratch?
It generally happens through one of two mechanisms. The first is a long, latent period of repeated exposure to a workplace allergen. Like a worker inhales an organic protein or a chemical sensitizer for years with absolutely no issue.
Right.
But one day, the immune system suddenly flips a switch, becomes hypersensitized to that specific substance, and triggers an asthma attack upon any future exposure.
And the second mechanism.
The second is an acute, massive exposure. Think of a worker breathing in highly corrosive agents during an industrial chemical fire. The sheer toxicity of that single event essentially burns the airways, leaving them permanently hyperreactive.
Jeez. And this latency bottleneck feels even more complex when we move to occupational cancer. I mean, the statistics from the Healthy Systems Report are sobering. 1 in 19 Americans will develop lung cancer in their lifetime. But when you look at occupational cancer specifically, 54 to 75% of them are lung cancers. We're talking about welders inhaling metal fumes, roofers working with hot asphalt, uranium miners.
And we must clearly distinguish between a traditional lung cancer and mesothelioma because they operate quite differently.
Right.
Mesothelioma is almost exclusively tied to asbestos exposure, which heavily impacted Navy veterans, shipbuilders, and construction workers throughout the 20th century. Biologically, mesothelioma isn't a cancer of the lung interior itself.
Oh, really?
No, it is a cancer of the mesothelium, which is the thin, protective tissue lining the outside of the lungs and other internal organs, though it is often grouped with lung cancers.
But the tragic thread tying all of these together, whether it's an ILD, popcorn lung, or mesothelioma, is that the symptoms almost never appear until the disease is highly advanced. Which brings us to the aftermath. But treating these diseases isn't a simple fix. It's a high-stakes, complex balancing act of pharmacy management.
Because these conditions are irreversible and lifelong, the medical goal shifts from curing to managing. And that management requires a deep, complex cascade of pharmacology.
What kind of drugs are we talking about?
Well, patients are typically placed on inhaled corticosteroids to aggressively suppress inflammation. They use bronchodilators to actively force the airway muscles to relax. If they have a fibrotic disease, they might be prescribed antifibrotics.
Which slow down the scar tissue.
Exactly. They attempt to interrupt the biological signaling pathways that tell the body to keep producing scar tissue. And then you have PDE4 inhibitors, which block specific enzymes to reduce severe inflammation in COPD patients.
So what does this all mean?
They have very complex safety profiles. If a physician puts a patient on high-dose systemic corticosteroids to keep their airways open, those steroids suppress the immune system and can significantly spike blood sugar levels.
Wow.
Yeah, prolonged use increases the worker's risk of developing diabetes, rapid weight gain, cataracts, and even osteoporosis because steroids can interfere with bone density.
That is a massive trade-off.
And if a patient is placed on PDE4 inhibitors, clinicians have to closely monitor them for severe mental health risks and sudden weight loss. Antifibrotics carry liver toxicity concerns.
And that's just the baseline maintenance. The report points out that these patients inevitably suffer from episodic flare-ups, a secondary bacterial infection, a sudden buildup of mucus, or even GER. This tension seems most extreme when we look at oncology. The Healthy Systems article notes a monumental victory, right? Overall, cancer deaths have dropped 33% over the last 30 years. But that survival rate comes with a heavy caveat regarding the standard of care, doesn't it?
It does. The biological breakthroughs in oncology have given us newer, targeted therapies that are far less broadly toxic than traditional chemotherapy. They are keeping people alive decades longer.
Which is amazing.
It is, but those newer standard of care drugs carry massive price tags. The irony of this medical success is that as survival rates improve, the complexity of care goes up, the duration extends indefinitely, and the overall financial burden skyrockets.
I want to ground this complex web of medications in reality. The Healthy Systems article provides a case study that perfectly illustrates both the human struggle and the financial reality of getting this right. It's the story of a patient named Eileen K.
Eileen's case is a textbook example of how the system can inadvertently fail a patient despite the best medical intentions. She is a 56-year-old woman suffering from severe asthma.
Right. She was struggling to breathe due to workplace renovation smoke. To manage her condition, her physicians had prescribed her Symbicort and Spiriva, so multiple inhalers.
But when clinical experts reviewed her pharmacy history, a glaring red flag emerged. Eileen was only refilling a 30-day supply of these medications every 3 to 4 months.
Which means she was spending the majority of the year entirely unmedicated. And the stats show that 70 to 80% of asthma patients use inhalers incorrectly anyway. Having multiple physical devices just multiplies that friction.
The burden of care was simply too high for her daily reality.
So the solution here is fascinating. A clinical recommendation switched Eileen away from the multiple inhalers to Trelegy Ellipta. This is a single, once-daily inhaler that combines 3 different medicines: an inhaled corticosteroid, a LAMA, and a LABA. What exactly is a LAMA doing biologically?
It's a brilliant, synchronized mechanical approach. ALAMA stands for long-acting muscarinic antagonist. Its job is defensive. It blocks the specific neurotransmitters that tell the smooth muscles around the airways to contract and tighten.
Okay, so it stops the constriction before it starts. And the LABA.
A LABI stands for long-acting beta agonist. Its job is offensive. It actively stimulates the receptors in those same smooth muscles, forcing them to relax.
So you are simultaneously putting up a shield to stop the muscles from tightening while actively forcing them to relax, all while the corticosteroid reduces the underlying swelling.
Precisely. It radically simplifies the physical act of taking the medicine.
And here's the irony that really blew my mind. So by giving her more inhalers originally, she was actually getting less medicine because the burden of taking them was just too high.
This raises an important question about the vital role of clinical pharmacists, because a prescription only works if the patient actually takes it. Eileen's old, complicated regimen cost $1,083 a month. That is nearly $13,000 a year.
And the new one.
The new single inhaler costs roughly $357 a month, bringing the annual cost down to about $4,200.
So total savings of over $8,700 annually.
Exactly. By recognizing that Eileen was overwhelmed by her regimen and consolidating her treatment into a single device with a lower barrier to entry, they didn't just save money on inhalers, they likely prevented multiple catastrophic emergency room visits, which cost exponentially more.
It is an incredible testament to looking at the whole picture. Well, to recap, the journey we have taken today is intense. We started with the visible sparks of longer wildfire seasons, zoomed in to look at the invisible, lifelong scarring of the lungs caused by ILDs and OLDs, and ended up navigating the incredible balancing act of pharmacy management required to treat it.
And the key takeaway for you listening today is a profound shift in perspective. Whenever you hear about a workers' comp respiratory claim, you are looking at a lifelong medical puzzle, not just a temporary injury that will heal with time.
Absolutely. And as we wrap up this deep dive, I want to leave you with one final thought to ponder. If climate change is expanding the fire season by a full month, and new industries are constantly creating novel chemical exposures, how long until our current rigid definitions of occupational hazards become completely obsolete? Will the ambient air we all breathe soon make occupational lung disease indistinguishable from environmental lung disease? Think about that the next time you take a deep breath.